pleasant good night. I am Dr. Woodley-Fassale, General Surgeon and the President of the St. Kitts Nevis Medical and Dental Association. Welcome to our next episode of Healthwise. A 14-year-old presented to our emergency room March of this year with a history of severe abdominal tenderness and bleeding through the navel. The patient had her appendix removed last year. She was admitted, ultrasound was normal, CT scan showed inflamed lymph nodes within the abdomen. White blood cells count was slightly elevated. Patient was seen by the pediatrician and treated conservatively. However, her pain persisted. What next? The management is to explore or look within the abdomen for a possible cause. On your screen, to the left, the patient would normally have the traditional open surgery, which we call exploratory laparotomy. However, on the right of your screen, the actual patient, she had 3 small keyhole-like incisions. St. Kitts and Nevis, welcome to keyhole surgery at the Joseph N. France General Hospital. Tonight we have an interesting lineup for you as we will be discussing what is keyhole surgery, the advantage of keyhole surgery, and who benefits from keyhole surgery. In studio with me tonight, I have Dr. Mark Grant, General Surgeon, who would introduce himself in the next episode, or in the next segment. I also have Dr. Nariani, who is no stranger to us, gynae obstetrician. And we have a special guest who will be joining us via Zoom, all the way from Jamaica, Dr. Lindberg Simpson, who is the president for the Caribbean Society of Endoscopic Surgeons, an organization that is committed to surgical excellence and supports the growth and establishment of keyhole surgery throughout the Caribbean, St. Kitts and Nevis being no exception. So we're going to take a short break. Stick and stay. Text your friends and let them know that we are on, because this is one episode you would not want to miss.
Here with another customer, and this customer speaks Spanish. Hi, what's your name? Let me try to ¿Cómo te llamo?
Oh, me llamo Jahaira.
Jahaira. All right, Jahaira, I know your English is not the best, but why do you shop at Value Mart?
Oh, me gustan los precios de aquí, son accesibles al bolsillo de uno, son cómodos, los vegetales todo fresco y es la mejor opción para venir aquí.
I don't know what she said, but it sounds good.
No sabe lo que te estoy diciendo, pero cuando los Spanish lo oigan van a saber que le estoy dando el mejor lugar para comprar, que es en Value Mart.
Welcome back to Healthwise. I am your host, Dr. Woodley, and I am in studio with Dr. Mark Grant and Dr. Nariani. We are here to speak about keyhole surgery at the Joseph N. France Hospital. It's actually a service that we are trying to establish officially. We have Dr. Grant, who has taken some time out. He's on his sabbatical and he has returned home to help out with the establishment of this unit. Dr. Grant, a special good night to you and thank you for being here with us. Can you explain to our audience, and which was something very interesting, that when I sent out the post last night, many persons were caught up with the term or the terminology, keyhole surgery. What is that?
So keyhole surgery goes by a number of different names. Laparoscopic surgery, some people may call it laser surgery, which is something different. However, it's using very small incisions to be able to get inside a cavity that could be inside the chest, could be inside the abdomen, and allows for us to be able to accomplish most of what we usually can accomplish in the traditional open surgery. It used to be promoted as something for cosmesis, in that you will have a small scar that no one can notice. However, we found that it actually leads to way less pain. We can see way better than we usually can see with smaller open incisions. It is less stress on the body, and most patients are able to get back to normal activity in a much shorter period of time. And with good equipment and training, most things that can be done with open surgery can be done laparoscopically. As you can see, that's the old keyhole, and so it allows us to see from the outside in, and that's the basic concept of laparoscopic surgery or keyhole surgery.
So, Dr. Grant, is this surgery something new? Is this a new modality to surgical practices? Because sometimes when we interact with, for example, the insurances and other persons who would deal with healthcare, and we reach out, we bring this topic to them, they would say to us, oh, this is something new. Is this actually a new practice?
So this is nothing new, as it has been throughout my entire career, which is just a bit over 20 years. And I have not known anything other than laparoscopic surgery or minimally invasive surgery, as some other people will call it. So nothing new, but it's relatively new in St. Kitts, and I would say kudos to Dr. Woodley for championing the cause.
Okay, thank you. I wasn't expecting that, but thank you anyway. And I also want to say kudos to you, Dr. Grant, because Dr. Grant is here, and he's put in a lot of tears and sweat into getting that unit up at the Joseph and Franz Hospital. Another doctor who latched on, and I was so happy for that, is Dr. Nariani. When I rolled out my plans to him that my hope, my dream is to create a robust endoscopic, laparoscopic unit, he was all for it. Dr. Nariani got so serious that he even purchased his own tower, which is something really commendable, and I am so happy for that. So Dr. Nariani, I'm going to turn it over to you now, and you are a gynecologist.
Yes.
So how does this fit into your role as a gynecologist?
Yes, well, thank you for having me on the on the show. Well, as a gynecologist, we deal a lot with the pelvic area, right, in the abdomen, and mainly with females. So we're looking at the uterus, which is the womb. We have the ovaries, and we also have the tubes, which all can give its own set of problems, right? So instead of doing, patients would come in, majority of our cases are issues with chronic pelvic pain, with fibroids, with bleeding, heavy menstrual bleeding. We have patients also who want sterilization in terms of tubal ligations to not to have pregnancies anymore. And doing it laparoscopically would now make it a lot easier. And the recovery time also is a lot less. So the patients don't have to stay in hospital for 3 or 4 days. They can go home either the same day or the next day. But interestingly, as a gynecologist, we have actually more to do, I feel, in terms of looking for the problem and finding solutions. So we have an area where we can look from above into the abdomen itself. And if you can look at this diagram we have here, if you can look at this diagram on the table here, where we have, can we get in it now? No. We just need to look at this.
Yeah, we need to look at the diagram. Mm-hmm.
At this model.
Okay. Mm-hmm.
Yep. Could we zoom in? Okay, no, okay, yes. Okay, good. Yep. So we have this model here where, so as you can see now, this is the uterus, or known as the womb as well. So we have the uterus here, we have the tubes coming off to the sides, and we have the ovaries. So there's in each case, there can be an issue or can be a problem. So let's start from the inside first, where now we can actually, with the help of a camera scope, which is a hysteroscope, we can actually look through the cervix into the uterus itself. So looking inside and seeing what problems may arise inside here. So as you can see, there's like a fibroid here, there's some polyps, there's adenomyosis within the muscle. So all this we can see on the inside, all right? And then that could give us a better idea of what is happening, what is causing the issue to the patient. And then we can solve that issue at the same time. So we see and then we treat it right away. So that is one area we can look at. This is also important with patients with fertility issues, unable to get pregnant. What is the cause, all right? So we can look inside, we can see the lining, how it looks, look at the entrance of the tubes, see how they look as well, if there's any blockages, etc. So that is one aspect. There's a completely different aspect to look into the uterus itself. Now we can look from above into the abdomen itself, and then we can look at the outer surface. We can look at fibroids on the outer surface. We can look at the tubes, if there's any scar tissue on the tubes. We can even look at the ovaries, looking at cysts on the ovaries. We can look for endometriosis, which causes a lot of pain, not related to the menstrual cycle, not related to the periods. So there's a wide array of things that we can look at. We can get a better idea of what is happening that may not be available on the ultrasound or the CT scan or the MRI. We can actually look and have a clear picture of what really is happening, what is causing the issue, and then we can treat it and provide a solution.
So that is why endoscopy, which is what you were just spoken about, that's part of endoscopy, just like keyhole surgery. It is so important that we use this now as part of our diagnostic tools. We're going to come right back. I see Dr. Grant itching, but we're going to come right back. We're going to take a short break, and when we get back, hopefully we should have Dr. Simpson online so he can unveil to us what his organization is doing to support us here in St. Kitts as it relates to keyhole surgery.
It's time that we realize that we must work together to thrive. The world as we know it, the sky and below it. Could I never have more wonder? Yeah, with life and all you see and the climate's changing. But hope is remaining. And we can't ignore the future. It depends on you and me. One chance, all that we got. One voice, together we start. Take care, the world where we live. Permite a todos vivir. Tomamos la oportunidad para cortar la humanidad. And I must leave no one behind because we are one climate, one Caribbean. One climate, one Caribbean.
Pleasant good night. And if you are just joining us, we are actually speaking about keyhole surgery at the Joseph in France Hospital. So far, Dr. Grant has spoken about it, about the advantages to be had when this surgery is done, as the incisions are very small. We also had Dr. Nariani, who spoke of this modality in gynae obstetrician, and he gave a wide array of examples. While we were on break, we were actually discussing that laparoscopy, or endoscopy as it is, actually started out with a gynecologist, which is very interesting. Because as I spoke with Dr. Grant and I asked him if it's something new, he said no. But if we realize this modality goes way, way back. We're gonna have Dr. Simpson coming in now, And Dr. Simpson is from Jamaica. He is the president of the Caribbean Society of Endoscopic Surgeons. I see him there. Hi, good night, Dr. Simpson. We give you a warm Kittitian and Nivision welcome to HealthWise. We know that you are supporting us here in St. Kitts as it relates to establishing our keyhole surgery department. And we have something very exciting to share with the public that is coming up in November. Can you just introduce yourself to our people here in St. Kitts and Nevis and let them know how you are supporting us and reveal to them the conference that we are going to be having in November?
Thank you very much, Dr. Woodley. Are you hearing me clearly?
Yes, we are hearing you.
All right, and I'll say good night also to Dr. Grant and Dr. Nariani and to all your viewers in St. Kitts and online. The Caribbean Society of Endolaparoscopic Surgeons is very excited about taking the world to St. Kitts in November. We'll be having our 12th annual conference, November 14 to 16. And I say bring the world because cases, the history of cases was formed out of a need by a few surgeons who had been trained in laparoscopy and were working in the region to recognize that there is a need for dissemination of the surgical skills that we had obtained overseas throughout the region to countries where these skills were not always accessible. And to do that, we also pioneered with some of our international colleagues, and we were able, I think, to successfully, in short order, we had a meeting in Curacao, just an informal meeting to discuss and try to come up with a framework for organizing such a meeting. And within a few months, we were to have our first meeting in Trinidad, and this was a success. And I think over the years, the meetings have continued to be a success, and we were really overjoyed when Dr. Woodley volunteered to take this meeting to St. Kitts. Now, this is important because at each meeting, we have been able to, in a significant way, improve the laparoscopic offerings in the country. By moving our meeting to a region, we have in the past successfully been able to, with the partnership of the host country and the government of the host country, improve the technical equipment which the surgeons there have at their disposal. We're talking about things like laparoscopic towers, disposable and reusable instruments for laparoscopy. And due to the structure of the meeting, where we have clinical cases being done and broadcast to the world, and also the discussion of these critical laparoscopic techniques, both the usual ones, the more common ones, as well as the more advanced ones, which perhaps won't be done routinely. That discussion, that performance of those procedures have resulted in a significant boost to the minimal invasive offerings in the host country. So what we're hoping for Grenada is that when we are ahead of time, before we get there in November, we will have been able to work with the local doctors, Dr. Woodley, Dr. Grant, Dr. Nariani, to work on building up their technical expertise, their resilience. And then when we leave, we would have broken new ground. We would have introduced surgeons across the world to St. Kitts, and we would have built up such a network for Dr. Woodley, Dr. Nariani, that A, they're comfortable doing common procedures, And should they encounter uncommon operations, there are many resources at their disposal to get these procedures done in a minimal invasive way, which is better for the patient.
Okay, so Dr. Lindberg, Dr. Simpson, I thank you so much for joining us. We just want you to hold on. We're going to take a short break because we want to let the public understand what we are doing here. This is something historic, it's iconic, and we are so grateful for the support that you and your members have given to us so far. So we'll take a short break and we will be right back.
We never know when a storm may strike, but we can be prepared. At Skelec, we work tirelessly to keep our customers connected. When a storm is approaching, we activate our hurricane preparedness and response plan. After the storm, our response teams will assess the damage to our network. If you are daring enough to go outside after the storm has passed, don't touch any downed power lines and stay clear of sparking wires. We'll need you to remain patient as some restoration work may take longer than others. Before restoration work begins, we will fix any damage to our power plant and transmission lines. Then we'll restore power to priority areas, beginning with essential services like hospitals, police stations, and water pumps. After that, we'll restore power to the largest number of customers on one feeder, which will take the shortest amount of time. We will then restore power to smaller feeders and individual customers with isolated problems. Be sure not to worry. Skelec is right here with you when you need us most.
Here with another customer, and this customer speaks Spanish. Hi, what's your name? Let me try to. ¿Cómo te llamo?
Oh, me llamo Jahaira.
Jahaira. All right, Jahaira, your English is not the best, but why do you shop at Value Mart?
Oh, me gustan los precios de aquí, son accesibles al bolsillo de uno, son cómodos, los vegetales todo fresco y es la mejor opción para venir aquí.
I don't know what she said, but it sounds good.
No sabe lo que te estoy diciendo, pero cuando los hispanos lo oigan van a saber que le estoy dando el mejor lugar para comprar, que es en Value Mart.
It's 11 for me. Okay, and welcome back to Healthwise by the St. Kitts Nevis Medical and Dental Association. Tonight we are speaking about keyhole surgery or laparoscopic surgery, and we're now making it a staple at the Joseph N. France Hospital. We were just speaking to Dr. Lindberg Simpson out of Jamaica, who is the president of the Caribbean Society of Endoscopic Surgeons. He's also the head of Surgery Kingston Public Hospital in Jamaica. And as the head of cases, as we know it, they are lending their support through expertise, through guidance in establishing a laparoscopic or endoscopic unit at the Joseph N. France Hospital. He also spoke about a conference that is upcoming in November of this year. In St. Kitts, the 12th Conference for Cases, or the Caribbean Society of Endoscopic Surgeons. David, can I get slide 8? This conference brings together great minds. This conference brings many expertise on island. This conference would start from the 14th to the 16th of November of this year. The dates are already etched in at Marriott Resort from November 11th all the way to November 20th. So for those of you who are listening in the diaspora, in the region, you can go ahead and start booking your hotel room to be part of this wonderful experience here in St. Kitts in November. Dr. Grant, while we wait for Dr. Simpson to come back in, can you give a little more explanation? Because persons may want to know, how do you get that camera on the inside of the abdomen? What happens? So give a little rundown, short but brief, on how this takes place.
So we create a very small nick in the skin, and then we're able to get a camera into the abdominal cavity. It's done in a number of ways, and I won't bore the general public with the surgical nuances, but we're able to get it in, and after we get it in, we're able to then put some gas inside the peritoneal cavity. And what this does, it lifts the wall away from the structures that are inside. And by doing so, we are then able to create a working space and hopefully decrease the risk of causing any injury to those structures that are right there. We then put in some things called trocars, which are additional keys to allow us to get in. And none of these tend to be more than the width of my finger. And using the instruments, we're able to manipulate and move around the structures that we want to work with.
Okay, so you say we have to put some gas in. And what type of gas? Is any type of gas we use?
So we use carbon dioxide as the gas, and the benefit of using carbon dioxide, it is not flammable, it is not toxic, and some of it, though it gets absorbed into the system, actually the body has a way of eliminating that gas from the system. One of the potential downsides, though, is that there's some patients who may have some pain in the shoulders because some of the gas gets trapped under the diaphragm, and the nerves to the diaphragm and the nerves to the shoulder tends to be the same, but that pain tends to be gone within about 24 to 48 hours.
Okay, so we are looking at the screen now for those of you at home, and someone may ask, all of those instruments, wouldn't that be painful?
So the point of pain is usually where the incisions are, and not necessarily because of the number of not necessarily because of the instruments themselves. The gas on the inside allows us to basically move around quite effectively.
So Dr. Nariani, I know you had a case recently.
Mm-hmm.
Dr. Grant is here and he's proctoring both of us, and thank you, Dr. Grant, so much. I give you your flowers while you're here with us. I want to thank you so much, Dr. Grant. He's proctoring me on doing many of the procedures at the Joseph and France Hospital, so that is a great relief to me. And about 2-3 weeks ago, you did a case with Dr. Nariani as well. So Dr. Nariani, can you explain to the public what that case was?
Yes, so I mean the case we had, it was a patient who was requesting tubal ligation, and she had completed her family, completed having her children, and didn't want to have any mishaps in terms of having another pregnancy at that age. So we were able to get her in on the same day, and as Dr. Grant explained, you know, we were able to get the camera in through the abdomen, get the gas in, and then it's basically a simple procedure where we just identify the tubes. So as you see, the tubes coming off of the uterus. We were able to lift those tubes. We were able to cauterize them using the so-called laser, and actually transecting it, cutting it with the scissors, and creating that space in between. So that was basically the tubal ligation that was done. And it took us around 15 to 20 minutes, the actual procedure itself. And the recovery time was about an hour, and the patient was able to go home on the same day and had an uneventful period post-operatively. We do advise after going home just to have soft food or just liquids for that day, and pain management with regular pain tablets was given. So the patient didn't have to stay in hospital, which was a benefit to them because they didn't want to stay in hospital for a prolonged period of time. Rather than the usual way that we normally do those procedures, we have to make a a cut in the bikini line. The patient would have to be admitted the day before, stay the day of the surgery, and then stay the next day. So about 3 days, they would have to stay in hospital. In this case, we were able to get them home the same day. And we do have some additional cases coming up, which will be quite interesting. And I suspect those patients will also probably spend a day or probably go home the same day.
So what we're looking at is the time that you would spend at the hospital decreases significantly. 1. 2, you get home and get back to your activities in no time. And 3, and I know Social Security would love to hear this, you get back out to work and continue with your contributions to Social Security. I know that's a big plus for Social Security. We are going to look at some of the procedures that we are doing at the Joseph and France Hospital. Dr. Nariani spoke of one already, which was tubal ligation. And Dr. Grant and I, we are doing quite a bit at the Joseph and France Hospital as it relates to keyhole surgery. So David, if you can give me slide 10. And we have quite a few things that we are doing there. And the patients are so appreciative. The family members as well are appreciative because they don't have this huge scar on the abdomen. So Dr. Grant, just go through what we have done so far, and we have done quite a bit. Kudos to us.
So we have removed some gallbladders. We've removed quite a few appendices that way. I recall recently doing one in which, had we done it the traditional open approach, it would have been very difficult to get to, and the laparoscopic approach enabled us to do it safely, and the child was out of the hospital in 24 hours. We've been able to do liver biopsies, we've been able to fix hernias, both your incisional hernias, what's called your belly button hernias, or even your groin hernias, which are your inguinal hernias. We've been able to do lung biopsies, and in some cases we don't really have an answer to what's going on. And even though we would prefer to get the answer from a CAT scan or from an ultrasound, if we are unable to get that, the laparoscopy is able to provide us that information. One of the things that many people have always spoken about, especially the naysayers who believe it can be done open, they would always comment on making a small skin incision. What you're not told is that below that skin incision, there's a much bigger incision to be able to get to what you need to do. With laparoscopy, what you see on the skin is it, and it doesn't get any bigger below that area. So the advantages of laparoscopy are well maintained. It also decreases the risk of wound infections after surgery because you're dealing with a much smaller wound. And it also gives you a much lower chance of getting a hernia after surgery, which sometimes can be quite problematic.
So David, if you can go back to that slide, you can see down in your right-hand corner, that's us there at the Joseph and France Hospital. That's actually Dr. Rollins from Nevis, who is a big supporter of what's happening. Actually, Dr. Rollins, he himself has done quite a bit of keyhole surgery over in Nevis. So it's just about time for us now in St. Kitts to make it more official, more consistent, so that we can be on par with our brothers and sisters over in Nevis. So I want to say thank you to Dr. Rollins, who came across, the shark-infested seas to help me out many times with laparoscopy, especially when we started out last year. Now, Dr. Grant, you spoke about diagnostic laparoscopy, and I want to zoom in on that because that is important. So, David, you're going to give me slide 11. Because, as you said, sometimes people say, oh, you can make a small incision and get what you want. But with keyhole surgery, this diagnostic laparoscopy, how important is this modality when we are uncertain about the diagnosis?
So for most cases, we always want to do what's called non-invasive to get the answer. And therefore, doing an X-ray, an ultrasound, a CAT scan would give us that answer. But sometimes we are unable to get that answer. And we still have a patient who may be suffering, or we still don't have an answer to that. So laparoscopy allows us to get that answer without having to subject the body to the major trauma associated with your open surgery. In many instances, sometimes people may say you can keep the patients in the hospital monitoring them, but by a diagnostic laparoscopy, many times we're able to get the answer and get the patient out of the hospital in a much sooner fashion.
Okay, I don't know if we have Dr. Simpson still online, well, via Zoom, because I really want him to speak to his colleagues out there in the region and internationally. We need you here in November. He's on? Okay, so Dr. Simpson, welcome back again. And we want you to give a warm welcome to your colleagues as it relates to the conference here in November. We have the rooms ready at Marriott. They can go ahead and book. So we want you to send out the invitation, Dr. Simpson, and once again, we want to say thank you for supporting us.
No problem, Dr. Woodley. Yes, to all the physicians at home in St. Kitts and listening, and also online across the region. You know what CASES is about. CASES is about mentoring in the form of our first day, which we do live surgeries, and those are usually very interesting, very informative, and we do that just because it's really important to get to see in real time what we really wanted with cases to be able to impact some of the smaller island nations where perhaps these procedures were not being done as commonly. And I just want to mention, our last two meetings were in Guyana last year, or even Grenada the year before. When we left, because of the invasion of regional and international experience, because of the depth of the informative discussion, because of the support of the local government ministries, we were able to comfortably say that when we left, we were able to leave both regions in a better state to do some of the surgeries that you guys have already been doing, and to help to make that the standard of care in that country, because we are talking about getting our Caribbean people healthy in as short a time as possible. So if there is a way, and we have the intellectual and technical expertise to do these procedures, get the patients better, decrease pain, get them home with their families, get them back out to work faster, we want to do it. So at CASES, we'll have live surgery, we'll have really good presentation, really good didactic discussions, really good reporting of case conferences, what regional surgeons have been doing. So really, if you're a surgeon in the Caribbean or across the world and has this interest, you really can't afford to not be in St. Kitts November 14 to 16. The only problem you should be having is if you delay too long and let the Marriott get booked out, we will find accommodation for you. So come, I promise you, you will not be disappointed. There will be interesting surgeries on the first day, and there will be very interesting discussions about surgical techniques across the breadth of minimal invasive surgery, not just general surgery or gynecology or urology. We have all the disciplines, and we will have that. And, at the end of that hard work to build camaraderie as Caribbean people, we will make sure that we have that bonding event that where, we all get to know each other better, and we build momentum for the next year. So on behalf of the CASES executive and family, I just want to extend the invitation. If you are a healthcare practitioner in the region, we look forward to seeing you in St. Kitts, November 14 to 16.
Thank you so much, Dr. Simpson. That was awesome. You're going to get your money's worth when you come to St. Kitts. Please book
Definitely.
early. That would be tourism month. And right after, we will be going into Carnival. So you're going to definitely get your money worth when you come to St. Kitts. You will be educated. You'll get some cultural experience. Man, St. Kitts is the place to be in November. So Dr. Simpson, we are looking forward, we are working hard, and you know that because we have our meetings, and we're going to make cases conference in St. Kitts, one that is marvelous, magnificent, and one that to be remembered. So we're going to take a short break, and then we're going to come right back.
It's time that we realize that we must work together to thrive. The world as we know it, the sky and below it. Could I never have more wonder? Yeah, with life and all you see and the climate's changing, but hope is remaining. And we can't ignore the future. It depends on you and me. One chance, all that we got. One voice, together we stand. Take care, the world where we live permite a todos vivir. Tomamos la oportunidad para guardar la humanidad. And I must leave no one behind because we are one climate, one Caribbean. One climate, one Caribbean.
Pleasant good night. And at this junction, we're going to have Winifred Weeks, who was a recipient of keyhole surgery, and she's going to give us her experience.
And welcome to this week's episode of Healthwise. I am Dr. Lescott. I have a very interesting subtopic for us to be engaged with Miss Winifred Weeks. So Winifred, the procedure that you would have undergone would have been called a laparoscopic procedure. I always get a bit tongue-tied. We are happy to have you, Miss Weeks. You can do a brief intro about yourself, your name, and let the public know who you are.
Okay, my name is Winifred Weeks, and I'm from Molyneux. And on May 2nd of this year, I had surgery to remove gallstones, right? I'm not quite familiar with the medical terms, but I can just say my gallbladder was removed because I was having a lot of problems with that. So I saw Dr. Woodley, and the procedure was done on May 2nd, which was very successful.
I must say, you're looking so sprightly. If you didn't tell me your age, I would never have been able to guess. The medical term for the condition which you suffered would have been cholecystitis. And I think it can be very extensive, and it can be very painful and uncomfortable as well, especially if you have any infection around the area secondary to the issue. So briefly, you could tell us like the procedure itself. I know it's new to you, but medically speaking, I don't think it's that new globally, but in St. Kitts, we are now utilizing endoscopies and camera-guided surgeries. And how was your experience with it? Like in terms of the recovery time, the comfort level, the pain level? Can you describe?
Well, to be honest, I'm afraid of surgeries, but I had that one. I was kind of nervous at first, but I went through it, and when it was done, I came back. Like I went to the hospital on the Wednesday, surgery was done on the Thursday, And by the Saturday I was home and there was not much discomfort. I didn't have any long incision, right? It was just a nip here and a nip there, like a mosquito bite also. But it wasn't very painful. Well, at first, soon as you come out, you might have some pain, but it wasn't that bad. So I was able to go home. I could have even gone home on the Friday.
Wow.
But I went home on the Saturday, and up to this moment, I'm feeling real good.
Wow, that's awesome. So when you were discharged and you were able to go back to your home, did you need any much assistance from anyone else? How was the mobility?
Well, I thought I did because the doctor told me I would need assistance, but the mobility was okay. I didn't need anyone. I live alone, but you know, some friends came by now and again to see how I was doing, but I could have managed on my own.
I can tell, you know, Winifred is the one, she's a very strong and sprightly lady. And she's even better looking in person. I don't think the camera does much justice for Winifred. Winifred is quite an inspiration to me right now. I'm happy to be sitting here in front of you. So in terms of pain, did you have to do a lot of pain management?
No, I just took whatever medication they gave me at the time they told me to, but there were no severe pains or whatsoever.
Okay, awesome. And in terms of the healing, did you have much scarring?
No, I didn't. Up to now, like I said, I just have some marks like mosquito bites or something like that, you would
That's
say.
awesome.
And, you know, I'm feeling okay.
And you're looking more than okay. You're looking
Thank you.
awesome.
Thank you.
I'm really happy that you came to join us on the show and to just tell the general public of your experience. And we are grateful to have the knowledge that you imparted upon us. So that's the end of our brief familiarizing with the procedure. And I'm Dr. Lescott again, and my guest was Winifred Weeks. And we thank you very much for coming and giving us a bit of your knowledge.
You're welcome.
And experience.
It was nice to be here.
Awesome. Thank you very much.
You're welcome.
Okay, we want to thank Dr. Lescott for interviewing our patient, Winifred Weeks. And as you heard, she said she had minimal pain. She had a whole army at home waiting for her to help her, but she didn't need them because she wasn't that handicapped per se after the surgery. We're now going to hear from the Director of Health Institution, Dr. Jensen Morton, as he gives us an update as to what is happening at the Joseph and France Hospital.
I'm Dr. Jensen Morton, the Director of Health Institutions, and today we're here at the Outpatients Department of the Joseph and France General Hospital to announce to the general public that the hospital's EEG department is now fully up and running. So an EEG is an electroencephalograph, and its purpose is to assist the neurologist with the diagnosis of different ailments affecting the brain and nervous system, such as strokes, seizures, movement disorders, and any other nervous disorders. It's the gold standard to assist in the diagnosis. Now, we were able to get from the Cuban government the services of a neurologist from last year, Dr. Alberto Laguna, and he did express the difficulties in working as a neurologist without an EEG machine to assist with aspects of diagnosis and tracking treatments. We reached out to PAHO, who answered our call and assured us that we would get an EEG machine in December of last year. We were pleased to announce that in March of this year, the EEG machine did successfully arrive, and we were able to get it not only set up, but also to ensure that all of our staff would be trained with regards to aspects of its maintenance, and to ensure that all of the persons using it were able to get fully oriented with its use. Today, we're going to have Dr. Laguna demonstrate the functioning of the EEG machine such that the general public could see how safe and effective of a treatment it is. I'd like to let the general public know that if they wish to get a neurology consultation, they can get a referral from any licensed physician, and the neurology clinic would be Mondays in the afternoons, and the EEGs will be done Wednesdays in the mornings at the outpatients department of the Joseph and France General Hospital. Thank you.
We want to thank Dr. Morton for giving us that update, a very important and timely update at what is happening at the Joseph and Franz Hospital as it relates to neurology. So Dr. Morton, I want to say thank you. I also want to publicly thank Dr. Morton as well, as he prepares the infrastructure of the hospital in collaboration with the Ministry of Health for the conference that we are going to have in November. Also want to shout out kudos to the Ministry of Tourism as well. We met with P.S. Wharton and she was very receptive. She loved the idea and has pledged to help us in any way that the Ministry of Tourism can. We're going to look now at who is a candidate for laparoscopic surgery. So Dr. Nariani, in your field, we're going to start out with you. Who would be a candidate or not be a candidate for laparoscopic surgery?
So I would like to just talk about the most common problem that we see here. And in the Caribbean in general, we are seeing a lot of fibroids, right? So we see multiple fibroids, very large fibroids, in excess of 20 fibroids in one patient, right? So, and in some cases, we may just see even just 1 or 2 fibroids, right? But they still cause bleeding, they still cause pain and discomfort, right? So, who would be a candidate to remove those fibroids via laparoscopy or open surgery? Those with the multiple fibroids, like 10, 15, 20 fibroids in multiple different locations, we will definitely have to do an open surgery because of the time, also blood loss, etc., right? So those who have just maybe 1 or 2 fibroids in certain locations causing them pain and bleeding, those can be done via laparoscopy because then we're able to work and focus mainly on those 1 or 2 fibroids and get them out cleanly and then stitch. Because remember, putting in the stitch is a different art in itself in laparoscopy. Taking it out is one thing, but then stitching is another thing, right? So that also takes a little more time, and then we have to be cognizant of the fact that there's always blood loss. So we want to minimize bleeding as much as possible, and we have the tools to do that. So we don't want to prolong the surgery, at the expense of losing blood. Right?
As an obstetrician, as it relates to pregnancy, can you do laparoscopy in someone who is pregnant?
Well, in someone who's pregnant, what they're doing now, and this is an advanced procedures, in maternal fetal medicine, they're actually doing fetal surgery. So when they find out if there's an issue with the baby inside the uterus, and as it is growing, as it is developing before reaching full term, they are able now to insert the laparoscope into the abdomen, into the uterus, to the baby, and actually do procedures, fix certain defects, and then come out, let that baby develop to full term, and then do the delivery. So that is definitely a laparoscopy in obstetrics, but that is more advanced surgery, and that is a different specialty in terms of maternal fetal medicine. So yes, it is, to answer your question, it is being done on the fetus inside the uterus as it is developing.
Okay, so Dr. Grant, in terms, to piggyback on Dr. Nariani, in terms of an appendicitis in someone who is pregnant.
And laparoscopic appendectomy is quite possible in the pregnant patient and is done quite often. I've seen it done up as high as 36 weeks. So it's certainly possible. The biggest limitation is usually the surgeon's skill or the equipment that may be available. But whereas it traditionally was said that you couldn't do laparoscopy in pregnancy, that is no longer something we adhere to.
Okay, so we had up the slide, David, slide 16, the candidate. So Dr. Grant, I'm looking at all of this. And I know I'm looking at the body mass index because once ago we used to run away from the fat. The persons who are obese with a body mass index of probably greater than 30. What is the new findings about that now?
Laparoscopy is safe in this group of patients and in some cases much better. because if you have to make open incisions, you increase the risk of hernias and you increase the risk of wound infections. It does raise some challenges, but laparoscopy in the obese patient is no longer something that's
contraindicated.
Yes.
Okay, so right there we have a picture of us, Mark, that's us in the OR. I think we were doing the appendectomy at the time. Yes, you know, I have my archives.
Yeah.
Dr. Nariani, please, I need you to, you know, be documenting via, you know, your pictures, etc. For the conference, remember we are all here, everything now pivots around the conference in November. And of course, after the conference, because our objective is to have a robust endoscopic unit. And this service we feel would be so essential and vital to our patients here, not just in St. Kitts, not just in Nevis, but in the region as well. What we have to remember that persons move back home depending on how good your healthcare system is. And if we can offer this service, many persons won't hesitate to come home. Also, persons go to places for tourism, to be a tourist, to have a vacation. And some persons choose their destiny areas or destiny countries based sometimes on the health system. So if they know that these things are happening here, I am telling you, we're going to have an influx, persons are going to come home, and persons are going to enjoy St. Kitts and Nevis. Now we're going to look at slide 15, David. And Mark, I know, Dr. Grant, I know you sometimes tell me that laparoscopy is not aesthetic, it's for the aesthetics. I beg to differ a bit. I see you're looking at me. But our aim in doing a keyhole surgery is to prevent this. What are your thoughts on this?
So the health benefits override all of the other benefits. However, I don't think many people are going to be unhappy if they have something that's cosmetically appealing at the end of the day. So we'll be happy to provide patients the ability to do belly button dancing until they're 70.
Okay, we're going to look at slide 14, and we are seeing some of the benefits. So, Dr. Nariani, when you saw that patient as an outpatient who you did the tubal ligation, you know, what was her experience? What was her feedback to you?
I mean, just on the day of surgery when she was discharged, just slight pain that she had, but she made a full recovery and was quite pleased, and I actually saw her a few weeks later, and she was doing quite well, went back out to work, didn't need much time at home, didn't need much time to recover. So she was definitely quite pleased and is back to her normal activities today as well.
Okay, so thank you. We're going to take a short break, and we will be back to wrap up when we get back from our short break.
We never know when a storm may strike, but we can be prepared. At Scalec, we work tirelessly to keep our customers connected. When a storm is approaching, we activate our hurricane preparedness and response plan. We monitor the storm and work closely with the authorities. We'll need you to ensure that there are no trees in the lines near you. If you need our help, call us for more information. It is likely that there will be a power outage, so make sure all your devices are fully charged. If you have a generator, make sure the changeover switch works. Ensure you have enough fuel and that your generator is isolated from the grid. It's best that you power off your main switch from the electrical panel and unplug all appliances. When calling to report faults, tell us everything. Don't leave any information out. After the storm, our response teams will assess the damage to our network. Be sure not to worry. Scalec is right here with you when you need us most.
Okay, so we are wrapping up. We had such a wonderful time here with you, our listening and viewing audience. And we spoke about keyhole surgery at the Joseph and France Hospital. This is just one of many discussions. We're going to come back in the near future. We're going to give you updates, especially as it relates to the conference that we are having in November 2024. I'm going to ask Dr. Nariani to give his closing, his outro, which will be followed by Dr. Grant as well.
Yes, so we mentioned all the benefits of laparoscopic surgery, and that we're moving forward into that area at the JNF hospital, which is a good thing. I would like to also thank, it wouldn't be possible without our nursing staff in the operating theater. So a special mention to our sisters, Lybert, Griffin, Stevens, our nurses, our theater nurses who actually assist us, like Nurse Osborne, Benjamin, David, Garnett, Powell. These are key to our success in laparoscopy because they have to be on board, and we are just one, we are just the surgeons doing the surgery, but those assisting us, getting the cameras ready, passing us the instruments are very important. So, and thank you to Dr. Jensen Morton and also the Prime Minister, Dr. Drew, who has allowed us the freedom to actually go forward and do laparoscopic surgery, creating that environment and that space for us to really push forward. And which will eventually then, and they have seen the vision, and it would eventually benefit patients, it would benefit the country in so many different ways.
Thank you, Dr. Nariani, and thank you for coming here with us today. We're going to have Dr. Grant now give his outro in half a minute because they're telling me we need to leave. Let's go, Dr. Grant. You're on a sprint.
So thank you very much again for having me here. I don't think we would have been this far without the perseverance of Dr. Woodley. And so I would like to give her what is her moment, because her perseverance is why we have made the advances here today. And I think we have more people like Dr. Woodley, we're going to get very far in advancing healthcare in St. Kitts Nevis.
Well, Dr. Grant has totally shut me up. So I want to wish everybody a great week. Be kind to each other and be safe. Good night.